Hi there, my name's Dr. Damien Rowland. I'm one of the consultants in paediatric emergency medicine here at the Leicester Royal Infirmary, and I'm here with Hannah Farrington, who will introduce herself shortly. And we're going to be talking about assessing and treating pain in children.
Hello, my name's Hannah. I'm a final year medical student doing my summer senior project in quality improvement. I have spent some time in the Children's Emergency Department at Leicester Royal Infirmary looking at how pain is currently assessed and managed. As a result of my time spent in the department, Dr. Rowland and I decided to produce this video to bring together the important information to bear in mind when dealing with children in pain. We will cover why pain is difficult to assess in children, a few techniques that can be used to help measure pain in children, how their pain can be treated effectively, and how we can help children and their families assist in managing pain. To start with, here's an example of how tricky assessing and managing pain can be in children. Whilst I was in the department, a 2-year-old girl arrived with her family after an accident on the trampoline when another child had landed on her leg. She was quiet and pale and was clinging on to Mum. It was difficult in this situation to determine if she was in a lot of pain or just frightened of the new surroundings.
And I think we've all experienced that type of case where a young child comes in and may be quite visibly distressed, but you're uncertain of the actual cause. And there's lots of reasons why pain is challenging in children. It's often challenging in adults as well, but there are some peculiarities. I think the most obvious thing is communication to begin with. Young children obviously don't have the developmental prowess to be able to explain what's wrong with them, and often even the children between the ages of 5 and 10 can't adequately explain exactly what's happened to them. But it's also a bit more than just simple being able to explain what's happening. Children often don't understand what's going on, and actually they have quite rigid thinking, so that they're unable to understand the possibility of more pain that they're experiencing at that given time. So it makes making a scale-based system very difficult. But there is also a challenge to healthcare professionals who see a child who might have quite a minor injury, who appears to be in a huge amount of pain, or sometimes vice versa. And the variation in individual responses to pain by children can make it difficult to assess pain scores. You add in the complexity of parental reaction to children's pain, and the whole situation can become quite challenging and very stressful for healthcare professionals.
A child's behaviour can give us a lot of clues about how much pain they are in. It can be quite easy for us to overlook a quiet child because our attention is drawn to a child who might be screaming the place down. Often, in retrospect, knowing the nature of a child's injury, their pain was probably worse than first realised. There are loads of different pain assessment tools that can be used with children. We've selected 3 tried and tested scales which seem to be the most popular and effective. As can be seen here, the Faces Pain Scale and Visual Analog Scale are both self-reporting tools that require the patient to point out their amount of pain. The Faces Pain Scale is recommended for use in children aged 4 and above, whereas the Visual Analog Scale is aimed at slightly older children aged 7 and above. For children who are too young to tell you how much pain they are in, the Flak Scale is particularly useful. This is an example of a behavioural tool. Whilst observing the child, you can score them in each of the 5 categories shown, and then add up the scores to give a total score out of 10. Whilst it's very useful for children who are too young to use self-reporting tools, it can actually be used for a child of any age. Don't forget that physiological signs can be indicators for pain, such as heart rate, respiratory rate and blood pressure, and so measuring these may also help your assessment of pain. Given the difficulties with assessing pain in children that have already been explained, it is useful to use a combination of tools so that we can be more confident that we have gotten to grips with how much pain our patients are in.
Here in Leicester, we've developed a paediatric pain assessment and treatment algorithm which combines a couple of the techniques that Hannah's just mentioned. And we brought that together from an original concept from Dr. Fionn Davies and then modified by a number of staff in the department. And the idea is it gives a clear visual clue to the healthcare professional looking after the child and assessing their pain as to different modalities. So you can go for a faces scale, a bit of behaviour, and add in an injury example, and enabling you to come up with a total score that brings in all the possible components of pain that we know about for children. So when we've done or assessed pain in its global nature, and we use kind of a mild, moderate and severe scale, we then need to treat the pain. So first of all, it's important to remember kind of distraction and non-pharmacological measures to assist with pain. Calming down the parent often helps, or moving to an environment where there is less distraction, less noise, maybe moving into a cubicle, for instance. In Leicester, we start with paracetamol or ibuprofen, move up to diclofenac and or morphine. And then if you're in a large amount of pain, we'll always consider Entonox, and we use intranasal diamorphine not infrequently on a number of our children. Finally, it's really important to remember to treat the underlying cause of the pain. So splinting the broken arm, reducing the dislocated finger, for example, will be vital to getting the pain under control. So you've measured pain, you've treated the pain. What next?
Regular re-evaluation of a child's pain score is an important aspect of good pain management. It allows us to determine whether their pain is being adequately treated or if they require further analgesia, and it means we don't overlook a child in pain.
So when we've made sure that we've got the pain under control, we've made sure that we've reassessed at a timely interval, and that we've made sure we've treated the underlying cause of the pain, what else can be done? Well, one of the things that we've discovered in our department is that we can empower children and their parents to assist with both managing their own pain, but also letting healthcare professionals know when they need more analgesia. First of the things we do is give the parents a pain passport. What that does is give them information on how to record pain scores, and they can write down with their child the pain that they're in so that they can feed that back to the nurse or doctor on review. We encourage communication between healthcare professionals and families and children throughout the patient journey. Play specialists are important in this regard because they're very good at picking up on the subtle features of pain and feeding that back. And actually, we can encourage children and their families to talk about pain outside of the hospital environment. There's some good studies suggesting that empowering parents to talk about pain scales and different types of pain with children aids the description of pain if that child does suffer a serious injury, for instance. So what we've done is we've just discussed a bit about measuring pain in children. We've looked at some treatment and looked at some things that parents and families can do to help their child. So thanks for listening, and we would be really grateful for any feedback, both on some of the stuff that we've been talking about, but maybe any initiatives that you have in your own departments that have proved really useful in improving the management of pain in children. So it's goodbye from me.
Goodbye. Thank you very much for listening.